So this one is about, well, we'll get at what it's about. So here's a 2-year-old kid who's previously healthy with a history of snoring. Kids do snore, speaking from personal experience. And the sleep study confirmed that obstructive sleep apnea due to a mild just genetic obstruction of the airway. And he undergoes an elective tonsillectomy. Very common thing. The outpatient surgery was uncomplicated. 6 hours after surgery, he received 10 milligrams of meperidine, which is Demerol, and 12.5 milligrams of dihydrogenate intramuscularly. Demerol, we're actually trying to get rid of completely here because we think that it's a lousy drug, and you can get much safer alternatives. But this is Demerol, still widely used by surgeons, so even though we're trying to get rid of it, it's still around. And discharged with instructions to take 12 milligrams of codeine with acetaminophen syrup, 5 cc's, every 4 to 6 hours as needed for pain in his tonsils. So there's a number of drug issues here. I'm tempted to spend time on, let me do it, on why we don't like meperidine. We don't like meperidine because in children who don't have developed kidneys, and somewhat in women who have less kidney function than men, but in anybody who has a renal clearance problem, difficulty with renal function, Demerol and its metabolites accumulate and they're CNS toxic. And all the other drugs we have in this class that are provide just as much pain control don't have that risk. So until very recently, when we removed it from the formularies at Wishart and Riley, we had 2 or 3 of these cases per year. But it's avoidable by just removing it from the formula. Anyway, in this particular case, so we've got a kid with sleep apnea who gets his tonsils out, got Demerol, and then is discharged with codeine. And then presented to the ER post-op for evaluation of mental status changes, disorientation. The parents report he's been extremely sleepy, he's not been eating and drinking very well. So in the ER, he's afebrile, has a heart rate of 80, blood pressure of 80 over 40, 88 over 45, breathing at 20 times per minute, and has an oxygen saturation of 94%. On physical exam, he's sleepy but arousable, and his exam is remarkable for pinpoint pupils. His labs, his white blood count, which is okay. This will be a normal hemoglobin hematocrit and normal platelet count. Calcium of 8.5, magnesium 2.1, a phosphate, normal range, and an ammonia was done, which was 40. And here's his Chem7. So he's got a normal sodium, a normal potassium. If you do the math here, he's got 125, 136, a normal anion gap here. BUN of 10, low creatinine, normal for his age, and he's not diabetic. He's got a glucose of 88. And his plasma morphine concentration, when that was measured, was high at 25 nanograms per mil. So what would you order? No additional testing, just decrease the codeine, somewhat rational. A drug screen to see what else, not necessarily what a 2-year-old was taking, but what was somehow accidentally available to a child. A pharmacogenomic test for 2C9, or a pharmacogenomic test for cytochrome P452D6. Now, see if I get this right this time. Once to time it, okay. Great. Okay. Now I think just lowering the codeine actually is very rational. I think a drug screen, this is another example. I think anybody who ordered a drug screen ought to be congratulated. It's a really very rational thing think about. Children often somehow get access to drugs that are in the parents' cabinets, or even crazy examples of getting hold of these things in elementary schools and so forth. So a drug screen's a totally rational thing. I wouldn't criticize anybody for doing that. 2C9, we don't worry about in this context. So unfortunately, I think this is probably one person or two people. This is wrong. And 2D6 is the enzyme that converts codeine to morphine, and it does it fairly exclusively, meaning that you don't have much morphine if you don't have this enzyme. So for the people in this room, there's about just under 100 people here. So we would expect that about 7% of all of us in this room would not make morphine at all. And even with high-end analytical technology, we can't pick up morphine in people who don't have it. So let me do a little poll here with all of you. How many people here have ever taken codeine that they know of for a fracture or something like that? Isn't that amazing? Right. A very high percentage of people in the room. I said it's among the top number of drugs prescribed. And did anybody not get any effect and just get sick with it? Yeah, it's about the right percentage. We had 10 or 15 people and one or two people. So this is very widespread, very common, and it has been argued that this is a reason for simply removing codeine from formularies. And in fact, that's what's been done at Riley because of this specific risk here. But among adults and throughout the state, we still have an awful lot of codeine. So anybody who says that codeine doesn't matter is dealing with 100 million plus prescriptions that they have to argue with per year. Very, very widely used thing. Okay. So here's just the explanation of it. So we want everybody to be good at this. So we want you to understand the contradictory things in the literature. People have said, oh, most codeine doesn't go through this pathway. Most codeine goes to another route and is made into norcodeine or the glucuronide. You know what? They're completely right. Most codeine does go this way, but all the morphine is made here. All the morphine is made here. So cytochrome P450 is required to make the morphine, and that's about as absolute a statement as we can make in pharmacogenetics, period. And then, once it's been made, it is cleared by these enzymes. And we're King's here from Chicago, but this work was done at Chicago. The UGT2B7 and UGT1A1 were shown to make 3-glucuronide, and these two enzymes were shown to make the 6-glucuronide. This is active. It's an active metabolite. And also, normorphine is made. This is a minor metabolite. But the key thing is that if you don't have any of this, you don't have any of this. You will get variability in this concentration due to reductions in this and in changes in these enzymes, but that's really not well worked out yet in terms of how we might adjust codeine dose based on these. So at the moment, this is what we spend our time on, avoiding giving codeine to people who aren't going to make this. So the pharmacogenetic reports that the child has a genetic variant in 2D6. This is a star 1, which remember is normal, and a star 2XN. And we haven't spent time on this, but Dr. Decker mentioned very briefly that there are people who have multiple copies of this gene. And multiple copies used to be only originally described in tumors, but we now know that they're not just in tumors. So this means this is, to me, an amazing piece of biology. Up to 13 copies of this gene have been described in one family. And mainly the percentage of people in the population runs at about 5% who have more than one copy. So in the family that had 13 copies, all 13 copies back to back are the same, identical. So they make the same enzyme, and these people are, we call them ultra rapid, very high rate of metabolism. So they would make a ton of morphine from the same dose of codeine. Okay, so you give the same dose of codeine to the same unsuspecting group of 100 people in this room, and these people would make up to 5 times more morphine than the rest of us. Okay, so one possible explanation for why this child is sleepy is that he's an ultra-rapid metabolizer. It could also just be an extensive metabolizer, makes a normal amount of morphine, and this is what happens to kids when you give them this much codeine. Intermediate metabolizer, it's in between. That would be someone who had one allele dead and one allele alive, or someone who is just a knockout, poor metabolizer. And they would have a high concentration of codeine, higher concentration of codeine. Right. So the question is, which of these, after all this explanation, is the most likely classification for this patient? I'm going to go 1. Good. I'm getting, there it is. Yeah. So he's most likely to be ultra-rapid, but a number of people, this wouldn't be an unreasonable explanation because this is a small child. Giving any dose of codeine to a small child is a little scary because you don't really know how quickly they clear it, and you don't really know what, if you like, the volume. I don't want to get into volumes of distribution, but you really don't know how far the codeine is going to go in that kid. So any kid is 2 you ought to be careful with, and this would be a reasonable thing. If they're an intermediate metabolizer, they would be in between. This is probably the wrong answer. Poor metabolizer is also probably wrong because in this case the kid is sedated, and codeine on its own, I'm going to exaggerate this to make the point, does nearly nothing in terms of sedation or in terms of pain control on its own. It does cause nausea, and we know that pretty well. And we know this because, we only know this because of pharmacogenetics. If you remove the morphine in a pharmacogenetic mutant, someone who doesn't have the enzyme, they nearly always get nauseated because of the high codeine concentration, but they don't get any analgesic benefit, no pain benefit, and they get they don't get sleepy. Now, people have said in this context, let me just see what I got next here. Yeah. This particular kid has 2d6 gene duplication, so they make a lot of morphine from codeine. They have an accumulation of morphine in the CNS as a result, and as a result, sedation and altered mental status. There are multiple reports here, and there are some very nasty ones in the literature of deaths of children in nursing mothers who are ultra-rapid metabolizers. So if you have a mother who makes a lot of morphine and a kid who can't clear the morphine because their glucuronidation capacity is still low, then that small group of people is very vulnerable to very bad things. And a number of infant deaths have been published in very prominent journals, The Lancet, the New England Journal of Medicine. That means we avoid this now. And this is another reason why the drama in these reports, I think, was another reason why Riley took codeine off the formulary. A couple of editorial comments about this. Number one is, people have argued, well, I can tell if my patient is getting pain control, so I don't need to do this genetic test because I can tell if they're in pain or not. But unfortunately, in this context, there are people children who can't tell whether or not, it's hard to interpret whether or not a child is in pain or not. And pain is an incredibly subjective thing. For the nurses among you who've handed pain medications to any age patient, you know that some people will complain regardless, and some people will not complain regardless. It has a lot to do with personality even. So I think this is a very objective thing. If they don't make any morphine and they don't have this enzyme, they are not going to get, it's impossible for them to get analgesic benefit beyond that available in a placebo control. Say that again, beyond that available in a placebo control, because that exists. The placebo effect is real, and people get benefit just from being looked after. But this is a very objective, useful way of determining that. So this had consequences for public policy. This is the FDA and the Wall Street Journal. communicating the fact that there's a safety review update for codeine use in children, and a new boxed warning, which is, of course, the worst, big, nasty warning that the FDA can make, and a contraindication on use of codeine after tonsillectomy or adenoidectomy. Now, this is what this looks like if you plot the number of patients in any population. So let's say this was 100 people. This could be this room, 100 people here. And the incidence of the people who either are poor metabolizers, who get no analgesic benefit, or who are ultra-rapid metabolizers. And this actually would be a little bit skewed out here, because I said this is about 3 to 5%, right, Dr. Scar? Ultra-rapid of the population. And this is in Caucasian populations, and we can spend a lot of time on the ethnicity here, but Caucasian populations, this is about 7%, and that was about what we got in this room. Right? It's a slightly lower number in Asian and African populations, but it's the incidence of this is replaced by a group in here, in both those contexts, in Africans and Asians. So what we recommend here is if you're in this big group, you get a standard dose of codeine. If you're over here, you start with a standard dose, and you might titrate it up because they're not. It's not working particularly well, and you can push more morphine, push more codeine through the morphine pathway by increasing the dose. In this group here, they don't get analgesia, so there's no point in using codeine. You can dose them all you want, and in fact. Famous study, I believe at the University of Maryland in the sickle cell clinic, where kids getting codeine in the sickle cell clinic were labeled, who are 2D6 poor metabolizers, were labeled as malingerers and drug abusers and so forth, because they're constantly asking for more opiate, constantly asking for more codeine. And the reason they're doing that is that they can't make the morphine. So there are 4 alternatives here, and this is reflected in the CPIC guidelines for codeine. Avoid it here, avoid it in the ultra-rapid context, standard doses here, and in this standard dose that you could up. Okay. That's codeine. This works to some extent for hydrocodone and not for oxycodone, and we can't generalize it across all those analgesics, unfortunately. But I think for hydrocodone, there's a case that can be made as well. Okay,